Our next speaker is Dr. Irene Say. Oh, yeah, okay. So she's an assistant professor at UCSF and a very valuable addition recently to our department. So she's going to give us the talk on spinal tumor management.
Hi, good morning. Thank you so much to Dr. Metz and Dr. Tan for hosting this beautiful course. And thank you for having me. Today I'll be reviewing a few different topics on the treatment of metastatic cancer to the spine, really a common problem that we all encounter, and some of the new updates about not just the surgical treatment, but also the medical treatment too. I don't have anything to disclose. So I'll first start off by showing an MRI and a few different scenarios that really highlight some of the nuances, not just in how we surgically treat someone, but also how we medically treat someone. And so you'll see this picture here, and for those of us who don't look at MRIs as much, you'll see this enhancing mass at T10, mostly on the left side, going into the vertebral body and into the pedicle. And so on the right-hand side, you'll see a few different scenarios of different kinds of patients and how we see them. And it really highlights how, based on the type of person that the patient is, are they a younger or an older patient with more or less comorbidities? Do they have a known diagnosis of cancer or not? And what is the suspected histology? And also, what is the patient's neurologic status and their degree of cord compression? And we'll talk about those frameworks later on. This is really a picture that highlights that metastatic cancer patients cancer patients can have a primary disease from all parts of the body, and many of them are ones that we are aware of, things like breast cancer, prostate cancer, lung cancer, and these patients are living longer than they have in the past, and the detection of cancer has improved significantly, partially because of imaging that's improved, access to care, and because of those things, we have to consider that not only is spine the number one area for bony metastasis to the spine, to the bone, but that what do we do about these patients who are living longer than ever and want to have a better quality of life? And so some of the major frameworks and the concepts of how we treat spinal cancer really fall into a few different buckets. And some of them are very common to other parts of spine disease. And we talk openly about this. Things like the concept of frailty is very common in spine research. And that's really at a higher stakes in treatment for spine cancer than really every other population, because we often talk openly about what is this patient's life expectancy. Now, if you hear this from oncologists, all oncologists will say the patients are living longer than 6 months. But this is something that we have to take into consideration really as surgeons, is that what is really the patient's systemic disease burden? And these are patients that are in and out of hospitals all the time. We know their wounds are actively going to get radiated. They are going to be taking steroids. And we know that really their time is really more precious than ever. And so how do we incorporate these things into our surgical plans and to our overall treatment plans? And really the last concept is, I think, trying to come out of our silo as spine surgeons and really understand how is metastatic cancer, how is it changing? And it's actually changing really at such a faster rate and for the better, in a way that is very catastrophically different than how we treat even things like primary brain tumor for the neurosurgeons in the room. And so the obvious is metastatic cancer patients have a high rate of complications. We know this, even this is work that's come out of UCSF by a joint neurosurgery and orthopedic spine research effort, really just an example. We are truly quite collaborative, that these patients not just have a high rate of things like wound dehiscence or breakdown or readmission, but really even some of the more serious ones like PE and reoperation and things like that. And we see this borne out in the literature, and large, even high volume centers all experience this problem. And so really no talk on metastatic spine cancer is really complete without some reference to Patchell's paper back in 2005. And really this represents a shift in the treatment paradigm of spine cancer. And that really up until about the late 90s, that really radiation was unfortunately considered kind of the most palliative number one option. And really this paper was the landmark paper that, we have all our residents read about how really how influential and how important spine surgery can be to protect a patient's quality of life. So things like continence and ambulation were really protected in this landmark paper. And then really I won't belabor this point. This is some of these concepts are topics that we use frequently. So the NOMS criteria, really popularized by Dr. Mark Bilski and Ilya Laufer out of Sloan Kettering, really incorporating what are the basic concepts of how we treat metastatic spine cancer. And with the advent of radiosurgery, really just catapulting the treatment for metastatic spine disease, we have to consider, of course, the level of the patient's cord compression, their neurologic deficit, maybe not just pain, but also weakness, oncology. What is the patient's suspected histology? Is this something very sensitive like myeloma or lymphoma, or is this something more radio-resistant like a sarcoma? Mechanical, and we'll talk about this with the SIN score, really understanding, is this patient stable or not? Do they need instrumentation? What kind of instrumentation, specifically between titanium or something like carbon fiber to really minimize that imaging artifact? And really systemic. Is this a patient that can tolerate surgery? And this is, we heard a lot about today about artificial intelligence in the last couple of days. And this is really some of the kind of key examples where incorporating all these things is almost easier said than done. And so that's why it's really important that we all kind of work together on that. The SIN score, again, really more of a modified Delphi approach that helps us understand, is this a part of the spine that needs surgery or instrumentation? Really developed as a way for us to communicate with our radiation oncologists, our radiologists and oncologists about trying to recognize, hey, does everything need an emergency consult? And really understanding this is a function mostly based out of radiographic parameters. The epidural spinal cord compression, really many different grading systems on this, but you'll see on the top left corner all the way down to the bottom right corner, really degrees of how the spinal cord can be compressed. And so kind of taking all of those concepts and kind of taking a step back, we have to kind of understand what are our goals for the patient. So surgical goals, which can often range from taking out as much tumor as possible, stabilizing the spine, preserving their function, but really also understanding what are the patient's goals. And so for cancer patients, this can be different for different patients. Some patients may just want their pain reduced to a level that's controllable. They may not necessarily care that every last molecule of tumor is removed, but they want, for the time that they have left, to feel as comfortable and as independent as possible. And really some of the elements on the right are things that we think about all the time as surgeons of what is our surgical approach. Do we do something more traditional, like a separation surgery, putting in screws and decompressing the spine? Or is this something that we need to say, hey, this patient is not going to benefit from a large surgery, perhaps radiation and cement augmentation with a kyphoplasty is better? And this slide is really kind of emphasizing that this is a team sport. And thankfully at UCSF, this is something that we do in spades. And it's truly quite collegial between our oncologists and radiation oncologists that we have a conversation about what's going on. And so kind of taking these techniques and taking everything that you may have heard about today, augmented reality, minimally invasive surgery, robotics and navigation, how do we take these tools and manipulate and harness them so that we can improve outcomes? And so these are things that you have heard a lot about today. How do we minimize a patient's blood loss, their OR time, their length of stay? And so these are some of the things that we kind of use. Operative considerations, and not to overwhelm you with a lot of this text, but really kind of taking those concepts is how do we confirm both the diagnosis? Let's say in the first scenario, where you saw a patient who did not have a known diagnosis, and really no one looks great, no one looks sexy operating on lymphoma. And so those are things that, how can we make sure that we do the right thing for patients, make sure they're optimized, that we can give them some realistic expectation of how they do after surgery. And then how do we use even things that are extra tools like like embolization from our radiology colleagues, or even plastic surgery to help us with patients who are actively getting radiated to their spine so we can prevent wound breakdown. And then really just having a nuanced conversation with in our tumor board. And so I'm going to kind of jump to that last category of, well, how do we understand how is metastatic cancer being treated in general? And I think it's very easy to not read that material because that's not really our specialty. We kind of focus on really kind of key concepts as spine surgeons, really. How do we decompress the spinal cord? How do we realign the spine and stabilize it? And some of this has been occurring over the last decade is that targeted immunotherapy, personalized medicine has advanced really in light years. And so it is not simply that patients get chemotherapy, but rather it is personalized to that specific tumor type. So you'll see on the left-hand side a cartoon of how this is done. And so, for example, this is a patient with breast cancer. Their specific tumor is analyzed for their tumor-specific antigens, and specific antibodies are made for that. And you'll see a large list of acronyms here of different kinds of receptors and antigens there. And it's really all across the board. It's breast cancer, it's non-small cell lung cancer, prostate, and thyroid. And really patients that we initially thought were, they're only going to live 6 months or even 8 months are living a great deal longer, up until, let's say, 18 months for non-small cell lung cancer for their certain tumor-specific antigens. And patients, for example, with prostate and thyroid live several years. And that's probably something that has very slowly crept into our literature and our understanding. And so this is a pretty dramatic picture here, but really an example of, and you'll see on the kind of the top row, you'll see an example of, let's say, a breast cancer patient with a metastatic disease to their lung, or that bottom picture with the red arrows, since we don't usually look at these pictures, but evidence of metastatic disease to the spine, and after getting tumor-specific therapy, that they almost disappear on a repeat CT scan. And so this is kind of an example of, if we know patients are living longer, we really do have to do a better job of making sure that we're doing the right thing for patients and understanding them. And so this is an example of a patient that happened to be in that third scenario. She was a patient, she had several comorbidities. She had a known history of breast cancer over a decade ago. And she presented with progressive back pain. And that's that lesion that we saw earlier. And really kind of the way, this is probably early on in my practice, but the way I helped treat her was kind of use some of those minimally invasive techniques and navigation and robotics to provide her with a surgery that did not expose her to a lot of blood loss, and really taking the concept of things like separation surgery, of doing really a transpedicular corpectomy on her and trying to get her out of the hospital really quickly. Okay, thank you so much for your time.
All right, Irene, great talk.
Thank you.
So I'll start with the question. So, it's always seems like a black box when you ask an oncologist, how long the patient will live before surgery. It's, 6 months or more. You end up operating. You did great, and, if you're great, and then 2 days later, they're withdrawing care for no reason. It happens all the time. I don't know. But so in patients, right now I have a patient where, she has metastatic breast cancer with cord compression. They've done, all the radiation, the chemo they can do. She had severe pain, still walking. Actually operated on her once 3 months ago, and she did great. Now the tumor has recurred. So she has recurrence pain, but she's, neurologically still intact. So what's your opinion? I mean, what should I do? Should we go back and debulk it again, which, is probably likely to come back again, versus just watch her and, when she develop a deficit, then operate, or just say, hey, this is the disease that's not really going to be cured with surgery, and what's your opinion?
Yeah, I think that's a great question. I think really highlights a lot of the topics of why this is so challenging, because there's really no one size fits all. Because if you ask a patient, would you like to undergo a repeat surgery? And that's such a heavy-hearted question, right? So I think it's really a combination of, this sounds so stereotypical, but you have to talk to the patient about what they would want. If they're intact, of course, you have that kind of time, that luxury. But this is kind of what's hard about that, is that to some patients, okay, it's a little pain that they can tolerate and do what they need to do with pain medication. But for some patients, if it is truly a quality of life, they cannot get out of bed, they cannot put on their clothes, they can't walk for longer than a couple feet, then I think you do have to consider reoperation.
Dr. Han.
Thank you.
So I have a question about the role of surgery in terms of length of survival of the patient. There are many papers that the surgery provides some benefit to the patients in terms of length of survival. Mm-hmm. So when you compare this group with the surgery plus RT versus RT alone, the surgery plus RT group has a more survival. But I think that study, most of the study has some bias in terms of selection bias in both groups. So what is your opinion about the role of surgery?
I completely agree with that. I think, but this also raises a question of, if we truly were to do a, randomized controlled trial, that kind of isn't, that isn't really as ethical as we would, so I completely agree with you. I think as surgeons, we have a complete selection bias. And until we get to that point where artificial intelligence and machine learning can kind of more definitively do that, we do have a lot of, as you know, calculators. For example, if you go online, I think I mentioned here the SORG algorithm, you can kind of input what is the likelihood of a patient in terms of their survival, if their risk of complications in the future. But you're 100% right. I think we all have this intuition, I guess, as surgeons, when we see a patient, that if someone looks very cachectic, they have long-standing, let's say, behavioral patterns or personal medical history, like smoking or a lower, a lower nutritional status. Those things are really, really hard to predict. But we have a great intuition of deciding, hey, who's going to really do well with surgery and who's going to crash and burn.
Oh, great talk, Irene.
Thanks.
I'm always perplexed at how you make a decision on how aggressive you are with your instrumentation. Like you want to give the patient a less invasive approach to decrease the overall potential morbidity of the surgery, given all the issues that you have to face with chemotherapy and radiation and post-op, which can decrease your wound healing. However, in doing so, you tend to instrument less, which creates a weaker construct, which may not last as long if the patients actually are going to live longer. Do you, and we're kind of generally going to like multiple rod constructs because we know the fusion may not heal, or whatever we do is not really healing. So how do you kind of make a decision from?
Yeah, that's a great question. If you actually spoke with Dr. Bilski recently, and in talking with him really kind of shows how difficult that problem is, because really in the beginning of, I guess when he really started the NOMS criteria, he wasn't doing a lot of, he was doing a lot of short segment instrumented constructs. And really because the patients are living longer, he's seeing a lot more instrumentation failures, rod breakages. And I don't have a good answer for you, Bobby. I think it's really hard, because on one hand, if you say, okay, I really want to prevent this person from breaking down, I'm going to give them a pretty multi-level 3 up, 3 down corpectomy, with an instrumented, with a metal cage to give them anterior column support. But then in the process, they suffer a major morbidity, right? They get a massive wound dehiscence. They come, and they can't tolerate that. It's really difficult.
Great talk. Thank you very much. I just had a comment and a question. So we actually recently looked at the different measures that we have to look at survival, and we try to look at the Tomita, Takahashi, New England metastatic score, and the SORG. And interestingly, we found that they were rather comparable. The New England score was a little bit superior to the other ones. But again, as you mentioned, discussing with the patient, this is just a tool. It's not like we just plug in and make the decision, becomes very important. So again, we find that making those decisions at our conference, where we keep kind of going back and forth whether this is the right thing for the survival of the patient, and they are surviving longer and longer. My other question was, since they are surviving longer, we've been using right around the region, like carbon fiber screws, screws that are not as metallic, because our radiation oncology colleagues really want to be able to irradiate those fields and also further image it. So what is your kind of take on using technologies like that at this point?
Great question, and thanks for bringing that up. I think to your first comment, I agree. I think there is such a mental gymnastics about what we do for each specific patient that is, quite honestly, so much harder than the actual surgery itself. I think a lot of the things that we do surgically are very similar to what we would do for any of the other cases you saw earlier for degenerative and things like that. So definitely the mental gymnastics is very difficult. And I think it's great that our industry vendor partners are here. So I think carbon fiber, especially for patients who are going to get repeat imaging for primary and metastatic disease, really for both, is ultimately it is superior for imaging in the future. But I think many of us in this room know that the cost of that, I think, ultimately is what is going to be more prohibitive. Now, what is it going to take for that to change? I think that's another talk. So thank you so much.
Irene, terrific talk.
Oh, wait,
I'm thinking about our graduating fellows about to go out into practice and them taking spine call, and they get this call at 8 p.m. that there's someone with metastatic tumor and a deficit. Do you have 4 or 5 pearls that you could sort of offer them in terms of optimizing the neurologic outcome? Do you do pre-op steroids, pre-op riluzole? Do you take them in the middle of the night?
So many.
How do you
pick my top 5?
Yeah.
So for all of the graduating residents or fellows, I think the first thing is pick up your phone. Okay, make sure you have good mentors that you can be honest with, and this is more on the social side, but don't be afraid to talk about cases like this when you come out of practice. I'm in my 3rd year of practice, and I still talk to colleagues and friends about that. So if you're not sure, even though you've done a very high-powered, high-volume case fellowship, it's very much different when you're on your own. And so I personally don't do, I guess your comment on riluzole, I don't personally do riluzole, although I know that some of my partners do. I know there has been some talk of course, off-label use of riluzole for things like myelopathy. Now, I'm not aware of it for metastatic disease. Decadron or use of steroids is a little bit tricky if they don't have a known history of metastatic cancer. There's always that classic adage of if it were a lymphoma or something like that. I think that's probably why, especially if you're at a smaller institution or that doesn't have, let's say, I think the biggest thing, to your point of, if you're in a smaller hospital and let's say you came out of an academic training, you may not have plastic surgery. You may not have a really great or reliable oncologist. So those are the things that I guess it's really more of an adaptation. So I guess pearls would be one, don't be afraid to talk to your colleagues and really bring up these cases. 2 is really nothing replaces examining the patient and hearing their story, and really just asking them, do you have any history of cancer? Surprisingly, so I also cover a smaller hospital other than UCSF, and unfortunately, they do not, really no one examines them or really talks to patients. So if you really examining patients on your own, and then really talking to your oncologist and your radiation oncologist, I think in most situations, they want to help you and they want to help the patient.